complete the question, then only they ask the next one. He said, I didn't want to interrupt you, so I didn't ask question. And he put that in the chat message at 6 p.m. Closing time, he has put that question in the chat, and that's chat screenshot he submitted to me. I said, if you want me to clear it, you could have posted beginning. When I was repeatedly announcing with messages, all the time silent. 6 o'clock suddenly you post the message. Okay, so how do we actually address your query? See, we tend to see clinically we have to take, even if it's an anatomy or biomechanics webinar, we try to see what to reality we can extend the knowledge to. Okay. In our clinical testing, whether we can incorporate whether surface anatomy for palpation or dynamic palpation for a movement testing for biomechanics, for muscle testing with movement testing for applied biomechanics. So various aspects can come. Even some of the special tests also needs to be analyzed biomechanically. Most of us, we see the special tests as they are all devised by orthopedicians. We just memorize by their name. And we think that the tests are different. The best example of such is the quadrant test and the Sperling's test. In the quadrants test also, extension, lateral flexion, rotation. Sperling's test also, extension, lateral flexion, rotation. So there's absolutely mechanically, if you see, both these are absolutely the same. But the addition in the Sperling's test is the maximum foraminal compression test. So that is where we give axial compression, adding on to that position. That is only for cervical, not for lumbar. So these are some things, even in a SLR, the straight leg raise, what we routinely do for a lumbar problem or sciatica, we tend to forget the biomechanics. Okay. Posterior pelvic tilt is happening. Posterior rotation of the pelvis will happen first. Next to posterior tilt will happen during SLR. And lumbar flattening is happening, the lordosis. And so it's not that which is right from beginning also, not only neural tissues, even posterior rotation of pelvis can be a problem. If that is restricted, symptom will come, even within 30 degrees of SLR. So that is why differentiation was told that ankle dorsiflexion will change the symptom. Okay. To see that it is neural. It's not that 30 degree means S1, 50 degree means L5, 70 degree means sacroiliac and hamstrings. Okay. So these are some things which we have to get over with. Beyond whatever the literature simply keeps on giving. Every edition, the new edition is coming, same information is coming, especially David Maggie. But if you see that the advancement of pathomechanics is so much that we have to extend our knowledge into the reality. Protocol-based application of tests or treatment will no longer be valid in reality, because every patient is different. And as Ritu ma'am highlighted in the last presentation, that today the patient how they are and tomorrow the patient how they are will be different. It is the diurnal variation. The the activities what they do in between, the body response. When three problems are there, okay, one problem is maximum problem, other problem is a moderate problem, and the third problem is a mild problem. So I tell it in terms of articular, myofascial, neural. So degeneration is maximum, spondylosis. Myofascial trigger point. Upon overuse, then the pain becomes severe. Radiculopathy, the nerve root compression. After what to say, a prolonged position, prolonged overuse, then combined with some days where the patient might lack a vitamin B12, okay, in the body, which is useful for the nerves, he might get or maybe a diabetic, for example, and that might fluctuate with the blood glucose levels. So that is neural, last. So that means joint degeneration may be major, spondylosis. Myofascial trigger point is overuse related, moderate, Radiculopathy is the mild one. So, in this scenario, when you are treating the joint for spondylosis, the lumbar spine, you are treating for the spondylosis, the day one. If you are on target, the spondylosis symptom will reduce and the condition recovers. So what will be the next day, the major finding? Patient will tell, when I'm pressing here, it is paining, sir. The latent trigger point which is there, either in the psoas major or quadratus lumborum. So these are some things which you should be able to adapt. You cannot tell that yesterday was spondylosis, orthopedician sent you as spondylosis. I'll treat the spondylosis, automatically that will go off. Or after I treat the spondylosis, then I will treat the myofascial trigger point. Okay. We are thinking that it is like people standing in a queue. First person gets the treatment. Like that, joints are first treated. Next is muscles. Next is nerve. No. But patient's body dictates that interrelationship between all the tissues. So that is why we have to apply the biomechanics into our reality. And when it comes to lumbar spine and low back pain, if you have to get a clinical problem solving, it is only possible through the pathomechanics. That is why many of the people are not able to understand the mystery of low back pain. They are not able to see that disc prolapse due to a degeneration. The degeneration is a spondylosis. So spondylosis creates a disc prolapse, and the disc prolapse creates a radiculopathy. And the radiculopathy causes radicular pain syndrome. Okay. So to every extent it goes. Or other direction is stenosis. Okay. So either radiculopathy or it is stenosis, foraminal stenosis. That also can come. So, of course, this presentation is intended to highlight the what is called as the scope of expanding your knowledge in applied biomechanics of the lumbar spine. Ritu, Sahni ma'am, our president of the AOMPT, she has taken the cervical and also the thoracic. Everyone is anticipating the third in this pre-congress webinar series of the second CHIROCON 2023. The Chiro Manual Therapy Congress and the workshop, the Certified Chiro Manual Therapy Practitioner. Although the course is an adapted version of the chiropractic to physical therapy as the Chiro Manual Therapy, chiropractic focuses on the spine. So this, of course, we had a spine course in Chennai that was also completed. So it's between all these courses that 1 week time now we have where we are enriching ourselves with this webinars on the mechanics, which is the applied biomechanics. So we will go into madam's presentation now and get on with the glory of knowledge. And participants must post their questions throughout the presentation. There is no reason why a participant has to wait to post a question. If the admins feel that question is a disturbance, means we'll disable the chat so that nobody can post. When the chat is open, definitely you can ask your questions. Because if you see Ritu ma'am and Dr. Darshana who are on the screen, they will clearly tell you that if there is one thing that is important in AOMPT webinars, that is always the questioning. Okay. So it's something which is automatic, that learning begins with the questioning. If you do not question, there is no learning. So we always encourage the thinking process. So it's not one question or it is even 3 questions. But point is, if everyone is asking questions, give space for everybody. Okay, not like so if you have 5 questions, you can put them in a single message so that we can address them together. And if nobody is asking question, you can ask a second question, no problem. Whoever is on the screen will get the first chance to ask directly verbally when we open the interactive session. So remember and utilize the session to the maximum, not just for certificate, but also for learning. Because everyone has certificates. We believe that AOMPT certificate is not just like any other certificate. So that is why we give for people who are learning, not for people who are just doing an attendance presence in the Zoom, okay, without even visible, without even asking questions directly, right? So yes, Darshana. So we move on.
Perfect.
Presentation now. Yes.
Yes. Eagerly waiting for Ritu ma'am's PPT.
Yeah, lumbar is always something which is the glory of knowledge. Easiest to understand the applied biomechanics is the shoulder.
Yeah.
More functionally where we can relate is the knee. Okay. Most difficult is the foot and ankle. Okay, there's no doubt about that. And when it comes to spine, it is like everywhere it is tough only. Okay. But most interesting because the low back pain patients are coming commonly than any other problem faced by a physical therapist in the patients, because that is lumbar spine, right?
Yes.
But the
Perfect.
name unfortunately resembles the Hindi lamba. Okay. So lumbar spine. Okay. Right.
Yes, sir.
So we'll move on now. When I resume the recording, madam can share the file.
Yes, sir.
Okay. The window view. Yes. Now slide view. Okay. Start, ma'am.
Yes, sir. Good evening, everyone, and good evening to you, sir. And we all are here with the sequence of our webinar related to the pre-Congress webinar sessions for our Chiro annual course, which is going to be held in the Bangalore at the 4th and the 5th of Feb this month. As it is also connected with the previous course on the CMAT course, where we have learned about the articular dysfunction in the Chennai, but now we are upgrading ourselves with the further and further in this field to upgrade that how judicially we can adjust the spinal dysfunction with the manual therapy, and it can be a very much beneficial because like the patient want a fast recovery, so for that it is a very useful agent which we use as the way of the pathomechanic and the way in understanding of the biomechanic. So for that, we are preparing ourselves for the practical demonstration in the 4th and 5th in the Bangalore. So it's our preparation is going on through the understanding of the spine, in which we have covered the cervical spine and the thoracic, and today we are going towards the lumbar spine. Because we know that whenever we talk, yes, the lumbar spine, it is very takes a very special part for the clinician, because as the patient comes to us, they don't know what is the word of the lumbar spine. They just say that I am having a low back pain. They don't know the cause of that low back pain, why this low back pain is causing. Maybe because of their articular dysfunction that we assess by their biomechanics. Either they are having a myofascial pain, yes, that we assess with the muscles contraction and resistance. Yes, they can be in the numbness and the tingling sensation, that also we measure with the neuromanual therapy or with the assessment of the nerves entrapment, like in the lower limb we know about the sciatica and the pseudo sciatica. So this is the way we understand their problem when they are in the low back pain, but they don't know. They just keep their hand that I am having a pain. They just tell when I am bending forward, then I am having a pain. They said that when I am going towards the backside, then I am having a pain, or when I am bending, keeping and taking something from the floor, that time I am having a pain. So this is the direction which they explain, only the low back pain. So now it's our turn to understand the biomechanics, in which direction they are having a pain of symptom in the aggravating way, or in which direction they are relieving the pain, or maybe their pain symptoms are in the peripheralization or the centralization. So this is our role to understand the biomechanics of the biomechanics of lumbar spine, which we apply on our patient when we do the movement testing, in the combined movement testing also we do, or by the special test which sir was explaining that we do for the testing of our patient. So this we made this a simple and small presentation about the lumbar spine, and we all are learning from AMPT in that last to last year we have already covered the certified special course for the spine, the lumbar spine course. That is also, I will say, the very best course of our AMPT, where we have covered all the problem related to this lumbar spine, either spondylosis, listhesis, radicular pain, radiculopathy, or the patient is having a myofascial pain syndrome, or the stenosis, or the dorsal radius pain syndrome, facet joint dysfunction, pathomechanics, biomechanics, everything about the lumbar spine. So for that, we are going to upgrade ourselves in this type of courses also. And the understanding of spine is always important, as the lumbar spine, that gives a special place in for all the clinician for day by day treating your patient when you see the patient is having a lumbar spine pain. So biomechanics of lumbar spine, the forces on the lumbar spine, we talk about that the movement due to the applied load, whatever the load, if I am sitting to standing, sit to sit to stand, or stand to sit, both in the direction, which load is coming, or maybe the kinetics way where the erector spinae force, the muscle part, we see that there is a erector spinae which gives the load, or in anteriorly the disc which share the forces perpendicular to the long axis of the vertebra. We know that the how the disc plays a very major role whenever the patient is having a disc herniation, or the stenosis, or the radiculopathy. So our assessment goes towards the disc, or the disc compressive forces parallel to the long axis, because one side they are getting the shearing forces coming on the disc. So one side it is getting the compression, and another side it is getting the stretch also, either in the lateral flexion or in the extension flexion, in the both way, because we see that maybe the herniation, the disc herniation is anterior posterior or medial lateral. So according to that, we see that how the compression, in which direction is the compression is coming, or in which direction is the stretch is coming. According to that, we understand it means which direction is giving the relief to the patient. In that, biomechanically we check, and after that we plan our treatment according to that. So for that, for the lumbar spine, the dynamic movement testing for the lumbar spine is also very important, because in these we see that when the patient is going in the bending position, that time we know that during the flexion position itself, if the patient is having an instability, or the patient, we have to check either the only the lumbar spine is taking place, or the pelvis is also moving simultaneously, or we have to see that how the lordosis different when we are checking with the extension, or how the thoracic spine, because we know that the L1, L2, that is closely related to the T11, T12. So it may be, there may be the dysfunction related to thoracic spine. It can be also affect the functioning of the lumbar spine also, or there like the kinetic parts, where the muscle association with the quadratus lumborum or the psoas major, they are closely attached with the lumbar spine. So they also take place whenever the patient is doing the lateral flexion. That time these muscles can be in the one side, the muscle can be overactive, and another side that same muscle can be underactive. So this is the way the dynamic movement testing for the lumbar spine is also very important. And not only in the sitting position, in the standing position, supine position, we have to check in all the direction, at which direction is aggravating factor, and which direction is the relieving factor. So in this also we check with that lumbar spine movement itself, how in the lateral flexion movement we do the in the standing position. So or we check that either the cervical spine or the lumbar thorax, it is also influencing the pain related to the lumbar spine. If the patient is, we are checking with the lateral flexion, that time also we check either the rotation of the thoracic, same time, same side thoracic rotation is giving the relief to the patient, or opposite side is aggravating. So this is the thing. Or we check either the patient is, when we add on the stability of the deep cervical flexors, we add on that stability. After that, we check that the movement is pain free. So it means there is a relation between the myokinetic chain also. So we have to see that if they in the lateral flexion, the lateral chain can be affect from one part to another part, or maybe the oblique chain, that can also be, maybe the patient is having a history of the shoulder pain, and after that the contralateral side they are having a tightness in the quadratus lumborum. It means there is a chain which is oblique chain is working, or maybe the lateral chain working from the full ipsilateral side. So we have to check all these things in the dynamic movement testing itself. We can do this testing. So this is the dynamic biomechanics which we apply during the movement testing, so that we can easily understand that what direction the patient is saying, yes, this direction I am having a pain. So we can understand that yes, there is a link between the contralateral side or maybe the ipsilateral side. So for that, the movement testing in the functional way, it is very mandatory, not in the supine position where the patient is lying down and then we are doing the testing. That time patient will not get any pain, or if in the resting position they are getting pain, that can also be a alert that maybe the autonomic nervous system or maybe the central sensitization or maybe any malignancy or the infection in the body, because of the that the patient is having a pain in the resting. So this is the way we have to evaluate the biomechanics in a comparison to a static versus the dynamic or the resting versus the functional activity, so that we can easily understand the mechanics of that particular area, which is influencing, or maybe the regional interdependence also can be influenced that region if we are checking about the lumbar spine. So for that, we are moving towards the first, we will see the kinematics. So what movements available? We all know about that. The flexion, extension, lateral flexion, and the rotation. These are the movements which are available in the lumbar spine. Or the gliding, anterior to posterior, medial to lateral, and the torsional gliding. It is also happening in the lumbar spine. And the tilting, anterior to posterior, and the lateral direction, there is a tilting happen, or the distraction and the compression. So these are the kinematics of the joints of the lumbar spine. With these movements are easily available in the lumbar spine, like you can see in this, the flexion, extension, and as well as the lateral bending and the axial rotation. So this is the way we understand about the lumbar spine, the which movements are easily available in that direction. So we have to check in this directions. And the ligaments, and during this biomechanics, the ligaments which also plays a very major role, that is the ligaments which gives the function and limits the function, that is the anterior longitudinal ligaments, which is we have already seen in our all the sessions of cervical and thoracic, that the anterior ligaments which are giving the coverage to the disc, posterior longitudinal ligaments which will give the coverage to the spinous process and the posterior side. So it will limits the forward flexion and it will limits the extension because they are anteriorly. Or the ligamentum flavum, that will also in the side, or the supraspinous in between the this is the spines, and in the spine there is a supraspinous ligament infra, and in between there is a infraspinous ligament. So that will also be when the patient will do the flexion, so that will also take the load that stretched by the interspinous ligament. So it limits the forward flexion because it will hold. So if there is an instability of in this joints also, so they will be in a slack position, they will not hold that particular spinous process by tightly. So there is a maybe there is a laxity because there is an instability of the joint. Because of that only, the articular, the myofascial, the muscles like the erector spinae or the multifidus, the if it go into the depth, or in the anterior where the disc, there is a the core muscles that will also play a major role, that will be in the tightness. So these are the things, the main ligaments that will give the function. They can be restrict for the dysfunction also. Or intertransfer ligaments, in between the transfer process there are a intertransverse ligament that will also play when the patient will do the lateral flexion. So if the same side the patient is doing flexion, so the contralateral side it will limits the flexion, so because they are holding the both the transfer process, transverse ligaments. So this is the way. Or the iliolumbar ligament, these will also resist the anterior sliding of L5 and S1, and as well as the attachment of the ligaments with the pelvis also, because we know that the lumbopelvic rhythm is there, or the ligaments which attach with the pelvis. So they will also give the movement to the posterior tilt, anterior tilt, that will also play a major role with the lumbar movement. So we cannot forget not because the last thoracic T11, T12, that is also influence the working of the lumbar spine, and as well as the pelvic function also influence the lumbar spine according to the attachment of the S1 to the L5 to S1 attachment with the sacrum. So it means if there is a sacral torsion, so in that also the lumbar will be influenced, the lordosis will be influenced. So this is the way it is important to see the biomechanics, not only see that the movement, the flexion, extension, the structures which are holding these structures will the major part of this biomechanics, because they are getting the force, they are going into the compression, they are going into the stretch. So it means we cannot forget these structure, which is not visible with our eyes, but we know that how important these structure it plays a role in the biomechanics of particular spine. In this lumbar range of motion, we know that the flexion, extension, axial rotation, and the lateral flexion, because normally whenever we do any activity, like we are we are in the kids, we see they do their lateral flexion, they play a game, and after that they do the lateral flexion. So how much, if they do more lateral flexion, they fall on the, so it means that there is a limitation of because with the spine there is a attachment of the muscles which are holding, they are giving the kinetic force to the spine. So they are having a flexibility of for a limited range. After that, if we will do that, we will definitely we will fall. So it means the we have to see that how much the range of motion is available for particular that function for the flexion, because the maximum is the flexion we are getting and the extension is less than the flexion, like the 50 to 15 degree, and the axial rotation as well as the lateral flexion, that is also 20. So it means the flexion and axial rotation has a limitation for the less degree, but extension and the axial rotation has a less degree of rotation, or the lateral flexion is better than the axial rotation, but the flexion is having the more, because normally whatever we do, that we do the banding, more banding is the in front banding we do more in compared to the extension process, or as well as in the walking also, we walk forward, we very less we use the backward steps. So this is the way the restriction comes according to the range of motion which is provided by our body mechanism, that is the biomechanics of the for the range of motion of that particular segment. So for if we talk about the lumbar flexion, so we see that the more limited than the extension, maximum motion at the lumbosacral joint, anterior tilting and gliding of the superior vertebra occurs, and increased diameter of intervertebral foramen also. In this also we can see that flexion generates compression force on the anterior side of the disc, tending to migrate nucleus pulposus posteriorly, because there is the, if we are doing the flexion, so it means that this is the flexion. If we will do the flexion, so it means that this nucleus pulposus anteriorly, it will get the compression, and then the posteriorly, it will get the stretch. So the lumbar flexion, so the nucleus pulposus will be tending to migrate towards the posterior side. So limited by the tension in posterior annulus fibrosus and posterior ligament system. So we have to see that in which direction patient is getting the compression by flexion, they are getting relief or they are aggravating their pain. So this is the way, if we talk about the disc, so in the flexion we can understand that why by doing this there is a compression is coming, or because of that the nucleus pulposus is migrated towards the posterior side during the flexion position. And this is the lumbar extension. Just opposite activity will be increase in the lumbar lordosis. In this also you can see when we are doing in the itself isn't doing in the lumbar extension, increase in the lumbar lordosis, posterior tilting, gliding of superior vertebra is happening, lumbar extension reduce. In this, it will reduce the diameter of the intervertebral foramen. We can see it in this picture also, that how when the extension is going on. So this is the disc, this is the joints, the foramen in the extension position. Compared with flexion, pressure is greater in the extension by more than 200%. In this also you can see with this picture that how during the extension nucleus pulposus displays anteriorly, just opposite, because in the flexion it was migrating towards the posterior side, and in this when we are doing extension, so it is coming anteriorly. So it means that the stretch and compression will be in different position. Like in this, the anteriorly the stretch is coming and the compression is coming posteriorly, because it is when we are doing the extension, so they are getting close, the spinous process are getting close. So it means there is a compression is coming, you can see it, or in the flexion it will be far, the spinous process will be far. So by this we can in our previous session also we have seen that how the compression and stretch during the extension and flexion taken by the disc as well as the nucleus pulposus with the compression and the stretch force. And this is the lateral flexion. This is also in the lumbar spine. We know that the lateral flexion activity, we know that we do some activity like if I want to pick something from the floor, so I will do some, maybe I will do little axial rotation or the rotation also, or as well as I will pick with the lateral flexion also, or sometimes we catch a pain when we are doing in the lateral flexion position. So in this also, these part is also very important for checking the lateral flexion during the movement testing of the patient, where the superior vertebra laterally tilts in this because there is a not flexion extension. So it will the superior vertebra, it will tilt, rotates and translate over vertebra in the lateral side because we are doing the lateral flexion. So it will not going in the anterior posterior position. So it will like this way, it will tilt laterally. So superior will tilt and rotate over the adjacent vertebra. So in this also the annular fibrosis compressed on the where the concavity or the convex, like in this picture we can see that there is this is the concavity and this is the convexity. So according to the convex and the concavity rule, so the annular fibrosis is compressed on the where is the concavity. So it will compressed is this in this side because there is a concave. The cave is coming here, so there is will be the compression on the annulus fibrosis on the concavity of the curve and stretched on the convex side. Because if I will do it, so there is the stretch and there is the compression because of my positioning of the concavity or the convexity. So nucleus pulposus migrates slightly towards the convex side. So where, like if I am bending, so this is the compression side, this is the stretch side. So nucleus pulposus will be towards the convex side. It will be slightly towards, it will migrate. So in this also, we can see that during the kinematics of this lateral flexion, so how the superior and inferior vertebral column, they guide and tilt laterally. And then that time also they give the compression to the nucleus pulposus or as well as the annular fibrosis. So in this also, you can see in this pic that how in this the lateral flexion it is coming. So these are the superior and inferior vertebra. So their the transfer process, they are coming together. So it means there are also the ligaments which are present in between the transfer process, or the ligaments which are present here, they will also get the stretch and compression. And if there is a axial rotation or there is a lateral flexion, so how it will behave. This is the extension flexion and this is the rotation. So in this rotation also the superior and inferior will be guided according to the rule of convex and concavity. And in this the muscle fiber that is also attached in the part of the kinetics, that we will see that how it will also be affected. So we cannot say that my patient is getting a pain during a lateral flexion, so that is the cause is only the vertebra or the spinous process, or no, I have to see that maybe the myofascial, the muscles, the external oblique, which are also the stabilizer of our body, and the latissimus dorsi, which are closely related with the upper limb activity. Maybe during doing the upper limb activity, that time during the lateral flexion, the patient is getting a catch. So it means this is the latissimus dorsi that is also, or thoracolumbar fascia that is also attached, or we see that the maybe the there is a motor control is not good, the endurance is not good to the subject, so maybe their internal obliques are also weak. So it can be the cause, or the quadratus lumborum. So these are the muscles which plays a very major role when we see the lumbar spine, or either with the lateral flexion, the quadratus lumborum is the first we think about that maybe there is a tightness of the one side of quadratus lumborum, so the patient is getting maybe the like the sir was saying that maybe we have treated the patient, but there is a latent trigger point which we see later on when the patient say that I am still having a pain in my lower back pain. So it means we have not treated that trigger points which were present in the quadratus lumborum. We have not seen that, we have not correcting why the patient is keeping their hand, or maybe some visceral problem is inside there, so that we are not going to check. So we only see that the patient is having a pain in a lumbar spine. So we only see that maybe there is a disc problem, maybe there is a radiculopathy, maybe there is a patient is having some numbness, so there is a stenosis. So we just focus on that, but there are some other things which we normally forget that maybe there is a visceral also, that visceral can be affecting the somatic also. So for this, the biomechanics is the term only Not only that, we will only follow the principle that vertebra is moving, that is the biomechanics, but vertebra influencing which structure, that is the biomechanics of a clinician. But what other structure can be influenced by this structure? If I am moving here, so what other structure is also affecting by my lateral flexion? We have to see that structure also. That structure can be, because the patient is having a pain in a quadratus lumborum, so I have to see that maybe the patient is having any surgery related to the stone, or the problem with the stones, or kidney related problem. Maybe they are having a bladder related any dysfunction. Maybe they are having a prostate related some problem. So it can be the during the biomechanics, we have to take the history also, to simultaneously we have to correlate what is the cause of my patient low back pain. Maybe if there is a woman, so maybe there is a because of delivery, because of pregnancy, or maybe the patient is obese, so the low back pain. And low back pain can be there are so many cause of the low back pain, not only the spine is only the cause. There are other things also which can be the reason for the low back pain. And this is the spinal rotation. The rotation causes movement of vertebra arch in the opposite direction. Ipsilateral facet joints go for the gapping. Like if we are doing the rotation, the same side of the facet joints, they will go for the gap. In this picture, you can see that. This picture, the axial rotation to the right. So the gap opening and the gap closing. So the same side rotation, there is the opening of the facet joints for the gapping, and the contralateral facet joint for the impaction. Because if I am doing the rotation, so it will be open side, or it will be in the closing, means it will get the little bit impaction. So axial rotation to right between L1 and L2, for instance, occurs as a left inferior articular facet of L1 approximate to compress against left superior. The same principle which we know, that the superior vertebra with their inferior articular facet with the inferior vertebra, their superior articulate, they will correlate with each other when the functioning is, the movement is going to be happen. In this also, the largest, the lateral flexion range of motion and axial rotation normally occurs in between the L2 and L3. So this is the way they see that in the neutral. If we see the lumbar spine, this seems like this in the extension. So how it is coming in the backward, so it is getting the compression, or in the flexion, it is moving towards, and in the axial rotation as well as the lateral bending. So how the vertebra, the joints which are related to like the facet joints, they are coming in the compression or in the stretch according to the lateral flexion of contralateral as well as the ipsilateral. So in this also, the spine rotation itself, we see that the how the ipsilateral facet joints are going for the gapping, and contralateral side, they are in the impaction. So this is the way we understand the extension, flexion, and lateral flexion and the spinal rotation, that are the major part of the lumbar spine movement. In this also, we can see that the couple movement, the spine coupling movement, that is the kinematic phenomena in which movement of the spine in one place is associated with the automatic movement in the another plane. So the most consistent pattern involves an association between axial rotation or the lateral flexion. It means the rotation is happening with the lateral flexion. With lateral flexion, pronounced flexion and slight ipsilateral rotation can be occur, or with axial rotation, substantial lateral flexion in the contralateral side direction also occurs. In this also, it is easily we can understand with the type 1 and the type 2 of that coupled motion. Type 1 means the one with the opposite direction. In the if there is a rotation in the right, so the side bending towards the left, because opposite side. The type 1 movement, side bending and rotation occur to the opposite side. That is the type 1, which we have remembered like type 1 to O to opposite side, because this is one, this is opposite. So we can keep in our mind. And type 2 movement, side bending and rotation occurs in the same side. So like in the cervical spine, in the type 1 in the upper cervical, there is a type 1 rotation, the coupled motion, and this is a simultaneously nobody is following these movements. It is the intent movement of that spine. It occurs I will say that it is the spontaneously movement which occurs in the spine when it is moving, like in the rotation in the right, if there is the type 1, so side bending will be the left position. Or in the type 2 movement, side bending and rotation occurs in the same side. Like in this, you can see that the rotation to the left and the side bending to the left. So this is the way we see that how we can understand the type 1 and the type 2 movement. And this is the lumbopelvic rhythm. That is also, whenever we see the lumbar spine, it also plays a very major role. The kinematic relationship between the lumbar spine and the hip joints, that is also very important during the sagittal plane movement itself. So how with the flexion movement, how the pelvis plays a major role with the lumbar spine that we see, or if we are doing the flexion, the forward bending, that time how the hamstring comes in the picture, they takes that the tightness. Some people have the tightness in the hamstring when we do, or the patient is having, we check with the flexion test itself that how only the lumbar spine is moving, or when we give the form and the force closure testing we do, we see that if we are giving the pack, we are just hold the pelvis and then the patient is doing. So we see that either only the lumbar spine take place during the bending, or the pelvis is also moving towards that. So this is also with the force and the form closure testing itself, or the flexion testing, we see that how the movement is happening only for the lumbar spine, and the pelvis is also moving. So maybe there is an instability because of that hyper instability, or the hypo instability of the pelvis, that also takes place during the lumbar spine movement itself. So this is the way the lumbopelvic rhythm is also very important when we see the kinematic relationship between the lumbar spine and as well as the hip joints. And this also bending forward lumbar flexion followed by anterior tilting of the pelvis at the hip joint. So it means that there is a, if we are bending, so the anterior tilting of the pelvis at the 70-degree, that pelvis will be tilt anteriorly and return to erect posterior tilting at pelvis at hips followed by the extension of the lumbar spine. So it means the movements are completely correlated with each other. It doesn't mean that if I am doing the hip flexion, so I know that the pelvic will be going into the tilting position, then the hip flexion will be possible. Or if I want to do the hip extension, so the pelvis rotation will be simultaneously, it will be happen, then the movement will be in the easy way. Or it may be if one is in stuck in position, so other functioning will be, definitely it will be in the dysfunction point of view. So we can see that how this is the kinematic relation plays a very major role during the flexion and extension with the lumbar spine to the pelvic rhythm. And this is also the integration of motion of pelvis about hip joints with the motion of vertebral column. It increases the range of motion available to total column and reduce amount of flexibility required to the lumbar region. And hip motions eliminates need for full lumbar flexion, protecting annulus fibrosis and posterior ligaments from being fully lengthened. In this also we can see it that during the flexion, how the lumbar spine is moving and how the pelvic movement is coming. So this is the way which I have already mentioned, that how we can check either the only the lumbar spine is taking place or the pelvis is also moving by giving the force to the pelvis, blocking the pelvis. Then the patient will do the movement to the flexion position. So we check that if the patient is not getting in that pain, so it means the pelvis involvement is not in there. But if the patient is having while doing the flexion, the pelvis is also moving. So, or after that, by blocking the pelvis, no pain. So it means the pelvis was the cause which we have given the force closure. We have blocked the pelvis. So the patient is doing the lumbar spine movement. So we have to differentiate between this movement of lumbar spine to and the pelvis. And this is the kinetic part, that is also a very, very important, because without the active forces, we cannot say that the joints and the ligaments, they will do their proper activity, because the support of active structures, the muscles and tendons is very important to give support to the spine. So for that, the kinetic part is also very important as a biomechanics, that how the compression, the lumbar region provides support for weight of upper part of body in the static as well as in the dynamic situation. Lumbar region must be withstand tremendous compressive loads produced by the muscle contraction. So in this also, we can see that how the compression forces are taken by the muscles which are attached to the spine. And this also that lumbosacral loads and erect standing posture in the range of that, how in the standing position the lumbosacral take the place during level walking of the range. It takes the body weight. Change in position of body will change the location of the line of gravity and thus change forces acting on the spine. Like if I am doing any my position is changed, I am in bending position or I am going in the extension position, that time the line of gravity will change, so that it will change the load on the lumbar spine. So lumbar interbody joints share 80% of load of these facets joint. The zygophysial facet joint in the axial compression share the 20% of total load. So these joints take the load, 80% of load of our body when we are doing any function. So, or it can be take the axial compression which share the 20% of load. So it means our body, the lumbar spine, it is taking the load when whatever the activity in the whatever the posture we are set to stand, and in the movement of the lateral flexion, extension, flexion. So they are taking the load of our body with the balance of the line of gravity of the body. So this is the way. And the muscle fibers which are closely related, that active force, because they are the contractile structures, they are the active structures, so they will maintain the spine. Because if these structures are the muscle fibers are like if we train the patient for the motor control, if these structures are not there, the core muscles or the muscles which are present like the erector spinae, the multifidus, these, or for the lumbar spine, the quadratus lumborum, psoas major, if these muscles are not there, so they will not, the eccentric control will be not there. So the muscles which we are in a lateral flexion, so we will keep it there only. But there are the forces which are working on the kinetics part. So these muscle work concentrically or the eccentrically. So they make the balance of these joints. If there is a eccentric control is very less, so it means the patient will get, when they will do the lateral bending, they will feel the pain. Or if there is a concentric weakness is there, so after coming back to their position, they will feel the pain or they will feel the catch. It means these active forces which are present in the form of the contractile structure, that are the muscles. So if they are, there is a any adhesion, there is a spasm, there is a tightness in this structure, so they will also affect the working of the spine, whatever the structure, either whatever the working like flexion, extension, and whatever the movement. But these muscles which are all around that spine, they are giving the support to the spine. If they are not in a working position, they will not allow to the spine to going back. So because of that, some people while bending they don't feel pain, but coming back they feel pain. Or some people while going in the flexion position at end range, they will feel pain, but coming back they don't feel pain. It means the muscle, the active structure, their concentric role or eccentric role is not in a proper way. Because of that, in one direction patient is not getting a relief, and in one direction they are aggravating their pain. So it means these structures has to be assessed. Either these structures are tight, either these structures are taut, either these structures are in the spas. After that, if we differentiate these structure, after that we can move forward to treat the patient. Or because of taking the compression forces, the neural structure which are coming from the spine, the lumbar spine, or maybe the stenosis where the spinal canal itself like a just getting in the compression position. So it is giving the compression to the spinal cord. So it is just like somebody is holding our neck, like feeling same like the stenosis is the feeling where the spinal canal itself going be into the narrowing. So the spinal cord, it will get the compressed. So it will give the pain to the lower limb in the both the side, not in the one side. It will give because it is the compression in the whole the spinal cord. So the patient will get the pain, the numbness, or in the their lower limb, that is going towards from the lumbar spine to the downwards in the lower extremity. So this is the way we understand that how important the kinematics to the kinetics, or with the neural component which are passing through these structures. They are the first victim which get either in the compression or either in the stretch, maybe the radiculating pain or maybe the radicular pain, maybe the radiculopathy, or maybe the radicular pain because of in the lumbar spine, the dorsal ramus syndrome. Because of that, patient is getting the radicular pain. So this is the way these the kinetic part is also very important to understand the spine biomechanics. And the shearing force, that is also very important in the lumbar spine, that in upright the patient is in the, or the subject is in the standing position, the lumbar segments are subject to take an anterior shearing force caused by lordotic position, body weight, and the ground reaction force. So it is resisted by direct impaction of inferior zygophageal facet of the superior, same the mechanism like the superior vertebra against the superior zygophageal facet of adjacent vertebra. In this also, the same in the flexion position and extension position, same the forces will be, the shearing force will be like the gliding in the flexion position, so it will glide, or in the extension position, it will be the superior or inferior vertebra, they will be in the opposite direction, like in the thoracic yesterday we have seen. So the same thing is happening in the shearing force, either the anterior posterior or the medial lateral shearing forces taken by the disc, or maybe the ligaments, or maybe the joints which are in the medial laterally, like the facet joints, they will be in the lock position. Either they can be locked in the flexion position, or they can be locked in the extension position according to the mechanism. Because whenever we see that the patient is doing their activity, if this is stuck in the extension position, the facet joint is stuck in the extension position, and we know that the extension, there is a closing of that facet, or in the flexion it is opening. So maybe this is the closed extension facet, so it will not be closed in the, because in flexion it has to be open, but it will not open because it was locked in the extension position, that was the closing. So when the patient will be coming in the flexion position, they will feel the pain on one side, because that side of the facet joint, that should be open in the flexion, but that is not going to be open. So it is still in the closed position. So it means it will be not, when if it not opening, so it means this is the closed facet joint of extension facet. It is in the flexion position, because it is not going to open. And the same phenomena, if there is a lock in the flexion position, that time that is stuck in the open position, because flexion is open position. So the facet is stuck in the open position. So while coming back in the extension, it should be in the closing position, but it is not going to close because it is stuck in the open position. So this is the flexion open lock, which in the extension position. So this is the phenomena of the facet locked. For that, if we are going to use the chiromanual therapy, our agents, the tool, that is the chiro activator tool, we are going to use it. So we are not going to use it blindly, that where we are going to utilize it, because we know that in which direction, according to the biomechanics or the pathomechanics of the spine, the facet joint lock is in which position. We have to check the movement itself, and in that position, we have to apply that activator tool on that particular region. By keeping, we have to check with the palpation of the spine itself. We have to see that where is the gap, by keeping our finger, that where is the gap is less in the extension or flexion. Then we have to apply the impulse of that activator tool. So this is the way in AOMPT, we are not blindly use any advent, any technique, any approach. We follow the principle, then we apply on our patient, so that our patient can be beneficial, can get benefit in a long-term recovery, not for the short-term recovery. Just I have listened the cracking sound, so I thought that facet joint is open. But my patient 4 or 5 days after that, if he or she is in the same pain, so there is a no any benefit of that cracking sound. So my the work for the main work for the basic is, it will be fail. So our purpose is to give the benefit for the long term, so that patient can recover for their dysfunction. And in this lumbar spine, as a part of the kinetics, the thoracolumbar fascia, that is also plays a very, very important role, as it is in the 3 layer, the anterior layer, middle layer, and as well as the posterior layer, and the deep back muscles and the quadratus lumborum, and the attachment with the external oblique, internal oblique, and as well as the transfer abdominal. So this is the way it acts as a stabilizing force set, increase spinal stiffness, mechanical transmission of forces between pelvis and the trunk through the thoracolumbar fascia. So this is also a very important whenever the patient is having a low back pain, because of there is a myofascial tightness, if there is a fascia restriction by doing the checking the facial play or the facial gliding. So we have to check that how we can give the gliding either needed towards the proximal direction or the distal direction. According to that, we release the fascia from the muscle. For that, also we have a fasciomuscular release techniques where we release the muscle from the fascia or fascia from the muscle as an active participation as a part of the biomechanics of kinetics of the lumbar spine, as well as the motor control retraining. There we utilize this fasciomuscular release so that our patient get a long-term recovery by releasing their fascia, by freeing the thoracolumbar fascia as well as the motor control, which give the better endurance to the patient working. After that, this is all about the biomechanic of the lumbar spine, which we have seen as the extension, flexion, how the facet joints, how the vertebral, the superior and inferior vertebra take place in the biomechanics of the lateral flexion. One side is getting compression and one side is getting stretch. So that's where we see that how the nucleus pulposus travel to the posteriorly when there is an anterior side is there is a compression, so it will migrate towards the posterior side, or if there is an extension, so it will migrate towards the anterior side, or if there is a lateral flexion, so it will towards the contralateral side. So according to the how the lumbar spine gives the line of gravity to the body with effect to the pelvis or as well as to the thoracic and the cervical spine. For that, we have learned this more about the lumbar spine in our certified lumbar spine specialist course from the AOMPT from last to last year. That was, I will say that that course has given us a better understanding to feel the problem of our patients which are coming for the low back pain. The low back pain, the cause may be the articular, the cause may be the myofascial pain syndrome, or the lumbar spine, maybe the neural component is there, so radiculopathy, stenosis is there, or maybe the patient is having the central sensitization, or they are having a history of any trauma and injury related to the lumbar spine where the central sensitization plays, or maybe the autonomic disturbances are there. Because of that, the patient is having a low back pain. So these are the things in this course. We have divided this course in the 10 parts where we have learned every part, every problem related that like the facet joint syndrome or the myofascial pain syndrome, with all the session with the pathomechanics, biomechanics, how we can apply, or as well as the manual therapy which is needed according to the patient centered approach with the training of the motor control. So this course was also a very upgraded course. You people can upgrade yourself by taking these courses. Like yesterday we have talked about the thoracic manual therapy specialist course, or in the cervical spine course. Like the same, this lumbar spine, like we know that the lumbar spine is the base of our body. So same like this course is the base of AOMPT, where we can upgrade ourselves by understanding the lumbar spine for understanding with the pathomechanics of the patient dysfunction and patient with the patient-centered approach. So this is, I have taken some screenshots so that we can easily understand and go through this, so that you people can also understand that how the sir has explained in this our CLSS course, how we understand if the patient is having a low back pain. So what is the cause of the low back pain? Not only that, by keeping hand is the low back pain. What is the main basic? The patient is having a pain because of sit to stand, they are having pain. So maybe the pelvis can be influenced. The patient is having a numbness, tingling sensation. So we can think about the compression of the foramen, the transfer foramen. The foramen may be the cause because of the radiculopathy or the radicular pain. Or the patient is having a like some people, the obese people, they are having a low back pain. For that is a different. Maybe the woman after the pregnancy, so they are having a low back pain. That is a different thing. So in this also, that sir has divided into in a different zone, which can be the cause of the low back pain. Maybe the organic, maybe the non-organic, maybe the obesity, maybe the any history which is like the central sensitization, or maybe the myofascial pain syndrome, the muscles which are in the tightness related to the lumbar spine, they can be the cause of the pain. So according to that, we have differentiated in a different way by doing the testing itself in the sitting position, supine position, side lying position, or in the functional, because if the patient is having a pain because of upper limb activity, they are having the pain. So it means we have to correlate that what is the cause, or because of the slouching position, patient is having a low back pain, it means thorax can be the cause of, or maybe the patient is sitting in the posterior tilting or anterior tilting can be the cause of the low back pain. So these all differentiation that sir has explained in this case, this course, that how the non-specific low back pain can be in a different we can divide into the different region also. And in this all the session that sir has explained with the pathomechanics of the facet joint, or the neural component with the myofascial pain syndrome, all the pathomechanics, how it we start our courses in AOMPT. Just like you can see on this blackboard also, that whiteboard where the sir was making the points, the notes, which we were taking the notes, and the sir was explaining to for our better understanding that what is the pathomechanics of the spine, the lumbar spine, how it, the like flexion, extension, lateral flexion, if the rotation, so how the facet joint is in this, they correlate with each other, or if the patient is doing the flexion, then how the joints are correlating. The same thing that sir has explained in this the classes. For every session, there is a 1 hour pathomechanics by which we get the better understanding for that which dysfunction or the patient restriction of movement we can easily understand by this pathomechanic session. And this is the myofascial pain syndrome, that how the patient is getting a pain, the myofascial pain, if there is a trigger point in quadratus lumborum, or the patient is having a trigger point because of the tightness of the psoas major, or maybe the patient is having a tightness in the hamstring, so that is also pulling forces coming towards the hamstring, so the patient is having a low back pain. Or the ligaments which are from lumbar spine to the sacrum, the ligaments are the lumbosacral ligaments, that can be the femur, the ligaments with the innominate bone which are attached, or the nerves which are coming, the neural components, so that can be the cause for the pain. Or the muscles, maybe the one side muscle is in a overactivity, so the patient is having a pain. So this is the way how the lateral flexion can be the cause of low back pain. So we check with the quadratus lumborum, there is a trigger point, maybe there is a spasm, so the patient is keeping their hand on that their low back area, so because of the spasm. So how we release with the muscle energy technique, the myofascial release, fasciomuscular release, or as an adjunct we can use the maybe IESTM, or we can use the cupping. So this is the thing, by after differentiating with the pain pattern of the patient, then we can utilize that which adjuncts we are going to use it. And this is the facet joint syndrome. I will say this was the very useful session, and very I will say appreciated that how the sir has explained the mechanism of the facet joints in the locking of the facet joint and extension and flexion position. So this is also on, and how with the lumbar spine, if the lock is the facet joint is locked, so when the patient is going in the bending position, so that how the sacrum will also moving with the lumbar spine, so how it will affect, because the facet joint is locked there, or according to their type 1 and type 2 movement. So this is the way we have to correlate all these things. So I will suggest that you people can take this courses like the cervical spine, thoracic, and as well as the lumbar spine. This will, I will say that worth learning. You will see that how much content sir has covered in this courses. You can't even imagine that how anyone can explain like this, just like a classroom class training like classes, where the movement, every movement with the, like sir has applied the tape. So how we can easily, that if that movement is going towards the flexion, so how the sacrum will also be moving towards with the lumbar spine. So with that, because if there is a facet joint is locked, so it will stuck. Maybe it will be the cause of the sacral torsion also. Maybe the unilateral side pain of the sacroiliac joint pain also can be the cause of, because of this locking. So this is the way we are understanding about the lumbar spine. And this is also the lumbar spine, that how we can understand about the stenosis of lumbar spine. This is also the way that sir was the tourniquet cuff, how judicially we utilize we check for with the arterial or with the venous system, that how the elevation or the dependent position, or how we utilize it for the venous and arterial, where we have to apply this stuff. So these things are also very useful, because we know that when the patient is having a stenosis, so they are having a pain in the both the lower limb. So how the aerobic activity, when they are doing some exercising like the paddling, like in this also that sir has explaining that both limb activity can relieve the patient's symptoms. So how we check with this cuff, we apply and we see the dorsal or the distally or the proximal according to the patient's symptom, and after that we check that in which direction patient is getting a relief. So by this, the sir has explained about the stenosis in our lumbar spine course. That is also a very useful session, because we see that the patient is having a pain. We never think that why the only the unilateral side pain or the both the limbs the patient is having pain. So we have to differentiate between that what are the symptoms according to the mechanics of that lumbar spine, or according to the mechanics of that how the spinal cord and the spinal canal, because of the narrowing, or maybe the radiculating pain because of that there is a narrowing of the foramen, so that the patient is the compression is getting through the nerves. Because whenever we talk about the lumbar spine, we never forget about the sciatica. So that is the first thing which comes in our mind when the patient say, I am having a low back pain. We just think that, oh, maybe the radiating symptom. So maybe this is the pain that you have a sciatica pain. So this is the thing. But we have to differentiate between these things, which you can, when you will learn from a proper channel, then you can understand that what is the differentiation between these symptoms of your patient. And this is also that lumbar spine, that radiculopathy, as well as the dorsal ramus syndrome, that how we check with the radicular pain, or the patient is having a pain related to the numbness, tingling, where the sciatic nerve. So how keeping in the SLR position, that time we check, or with the we see that the giving the sliders to the sciatic nerve sliders with the like, then with the flexion of the leg, with the plantar flexion or extension with the dorsiflexion, we differentiate, we give the sliders, we see that either the patient symptoms. So this is all the applied biomechanics. While doing the evaluation and assessment itself, we have a plan of in a backup plan of the treatment. Like I need a neuromanual therapy, I will apply neuromanual therapy. If the patient is having a spasm, I know that what kind of approach I have to give here. So these are the things we keep in our backup mind whenever we do the evaluation. Simultaneously, we try to give the treatment in a first session itself, so that the patient get relief from their symptoms. So if they are holding their hand on the back, so that hand should be in the side position. So because of their getting relief from our evaluation as well as the treatment. So for that, the biomechanics understanding of the mechanism of that particular joint is very, very important, so that we can evaluate and as well as we can treat the patient. So this is all about that our CLSS course. That is, I will really, really, really recommend to everyone who are sitting here. There is, if you will upgrade yourself, you will feel happy that what you got from AOMPT, because we, like me and Darshana ma'am, we know, and the Nitin sir, Chaitanya ma'am, because we are feeling fulfillness in our thrust after learning from this type of courses, because we see that our patient problem, we understand the logic that why the patient is having a pain because of the lower back pain. So for that, you people can don't think that you are learning from the books or whatever the this webinar, because in this we can explain in our boundaries. But when you will learn, you will take the course, you are having a privilege to for the lifelong access of the videos. You can anytime, whenever you get the time, you can see that particular, if you are having a patient of the stenosis, that time you can open that video and you can correlate with that video. Yes, my patient is having the same symptom, so I can go through this channel. So this is the way you people can get benefited with this, because this if this type of facility is available in the online, I will think we should never miss it. So it's a blessing from the God, because if we are in the profession, so we should do the justice with our profession by learning from a right way so that we cannot worsen our patient symptom. So for that, these words, I am going to stop my presentation, and I want to dedicate it, as always, this presentation to sir. Because of him, we are learning, and Darshana ma'am also. We both enjoy all the classes together, and we enjoy in the class also, and we learn. And Nitin sir, he is also the part of our every class. Chaitanya ma'am, she is also be there, and all the other members which are not present on that time on the Zoom, but they are also the part of that course. And they are going to upgrade it. Now you can easily understand for the chiro manual therapy itself, how much we are talking about the pathomechanics, biomechanics, anatomy of the spine. So it means we are not going to use blindly that activator tool in any direction. We are following the principle. It's just like there is a eye of the fish in front of the Arjuna. So we have to focus on that eye. We are not giving that arrow in any direction. We know that in which direction we are going to give the impulse according to the patient is having a problem in extension flexion. So I should know that in which direction I have to give the impulse. I have to work on the spinous process which are in the same plane. I have to give the transfer direction. So which, if I want a rotation, so I have to go towards the transfer direction. If I have to go towards the facet joint that is going in the lateral, the facet joint syndrome, so how I will use that impulse in that particular area where the facet joint is present. So it depends upon the direction. So our focus should be clear. Although my eyes are not in a right focus at this time, but I can see my focus, that my focus is on the my patient symptom where I have to give the impulse. So I want to correct my patient capability, which function he is not able to or she is not able to perform. So with that, these words, I am going to stop my presentation. Thank you so much, everyone. And please upgrade yourself. Don't think that another time I will take or I will take in next month. The step which we take at random, that will be the always the best step, because that takes us to the different world. So please take your decision on a right time so that you can upgrade yourself. So thank you, everyone. And thank you, sir. And my presentation is dedicated to sir and ma'am also. With this word, I am going to stop my presentation. So thank you, everyone. And thank you so much, sir. Yes, sir. Over to you, sir.
Yeah.
Sir, I'm
You want to switch to the phone? Yeah.
switch off, and just mom is calling. I'm coming in a 1 minute.
Yeah. Ask Babu to go. Yeah. Darshana. Dr. Ram Keval Vishwakarma. Dharmesh Lugana. Yeah, he attended a webinar some time back. Pranali. On screen, whoever is on screen and who has already posted the questions in the chat. Where it is, Pranali has posted. Yeah, how to manage loss of lumbar lordosis with spondylolisthesis. Okay. Interesting question. But I will want her to explain the question. Yes, Dr. Pranali. Yeah.
Yes, sir. Thank you. Good evening, sir. Good evening, ma'am. So my question is how to manage loss of lumbar lordosis with spondylolisthesis L5 over S1 along with pseudo bulging of disc.
What you are saying now is a radiological report. Am I right? Darshana, are you able to see Pranali?
No, I cannot see her.
She's off the video, I think, internet.
Yeah, maybe. She's not there.
Okay.
Yes.
Because clear nomenclature and the terminology what she was describing It is a MRI report, or at least a X-ray. You cannot tell a disc bulge. Okay, so it should be a combination. Okay, so what at first point I always in a lighter sentence we tell is don't treat the radiology, treat the patient. Okay, so a flattened lordosis is not a malignancy or infection that they require immediately treatment. Okay, lot of people have flattened lordosis and there is absolutely no symptom at all. And when we talk about listhesis, commonly L5S1, you see the curvature itself, L5S1, the angulation of lumbosacral angle, L5S1 has the highest chances of going for listhesis. So even an extended, okay, so that is like L5S1 listhesis mostly here, you will see like L5 is extended, the more opening anteriorly. That is the listhesis. It's not the slipping. Okay, in L5. L4-5, it is the slipping, anterior translation. L5 is not the anterior translation, it is just the hyperextension. Because that is the gravitational moment, the extension at S1, the center of gravity. So, the listhesis at the L5-S1 might go ignore if people are looking at an X-ray directly. You might think that there is no forward slipping. Okay, but the vertebra has opened more. Okay, and especially these listhesis are diagnosed not static, standing position. We have to see in flexion how it is, in neutral how it is, in extension how it is. So it's called as the functional radiography or flexion extension radiography to tell whether there is that particular segment is more unstable compared to the other segments. In a rough idea, it is linear instability is beyond 3 millimeters. Angular instability is beyond 3 degrees. So rule of the threes, similar to that, this is also 3. But this does not actually get us into any kind of a clinical picture, because listhesis also, even grade 3 listhesis can be asymptomatic. Only the grade 4, because of pulling the nerve root, or if it is traumatic listhesis, after a chiropractic or osteopathic manipulation, people can get pars intraarticularis fracture. That is also traumatic listhesis only. Cracking sound will come, but it's the bone cracking. As you see in the YouTube videos, that cracking the deepest bones. Okay, opening the muscle knots. Okay, all this terminology they use, non-scientific terms. So something non-scientifically also happens in that treatment techniques. So remember that flattening of lordosis can be asymptomatic, listhesis can be asymptomatic. And the third picture, which is like a pseudo bulge, that's the first time which commonly in a conversation we are hearing. What is a pseudo bulge? Okay, a disc bulge, which is a pseudo bulge, a false bulge, means what is it? Why it is called as a pseudo bulge? Okay, so that's something which is very important. It's interesting to note. Unfortunately, she is okay. She's back. Okay. So these the third point. Yes, Pranali.
Yes, sir. My network connection was,
Yeah.
so that's why. But right now.
Okay, some किसी ने नजर लगा दिया. Yeah. Because throughout you are the only person who are visible on the screen other than Darshana and me. Okay. So somebody has put eyes on you. Yeah, tell me. Are you listening?
Yes, sir. Yes, sir. So my question was that how to manage patient with the loss of lumbar lordosis along with spondylolisthesis L5 over S1 and with pseudo bulge, disc bulge, basically in basket players. So because there was a patient, so I would like to know more from you that how in such.
Were you listening to what I was talking?
Yes, sir. Yes, sir. I listened that you gave the explanation about the spondylolisthesis. Yes, sir. I heard, but I would like to know that what is the pseudo bulge, disc bulge.
You want to know what is
It is-
pseudo bulge?
So it
Is this the MRI report?
yes, sir. Yes,
Okay.
it's the it is MRI
When
finding.
the radiologist is using a term, radiology textbooks will be the best to identify what exactly the context they have used that. Okay.
Yes, sir.
For example, I will tell you a story. When it comes to idli sambar, whom you have to ask?
Yes, sir.
People in Chennai or Tamil
Can.
Nadu. Okay. Some extent you can ask the Kerala, Andhra Pradesh, okay, or Karnataka. But when it comes to Pani Puri, whom will you ask? Okay. So there are people who can handle that specific things. Moment I talk about 5 different varieties of idli or 4 different varieties of chutney with the idli combination. You want to clarify about the idli means you have to ask me only.
Yes.
So that means whenever you see a report, don't focus on the report more than focusing on the patient. Because you are trained to treat the patient. You are not trained to treat the X-ray.
X-ray, right.
Or the MRI. We are not treating the MRI. We are treating the patient. When we look at the MRI, only when patient has come to you first time without physician any consultation, patient has taken the MRI themselves and they have come to you. That time you can look at the MRI. Because before referring that patient to a physician, you want to see whether there is any serious pathology. Red flags, what we commonly call. So that is the situation where you look at the MRI. And when you talk about Ritu ma'am, did you come across any terminology like pseudo disc bulge? Darshana?
No,
What is
sir.
your perspective and input?
No, sir. No idea about this.
This is like, for example, see, annulus fibrosis is here, all outside. This annulus fibrosis, because of a poor posture, always we sit like this, okay? A flexed posture or flattened lordosis, like in that situation. Annulus fibrosis, the posterior annulus becomes lengthened. It gets lengthened, but the subject is a physically active individual. Because of which, the annulus fibrosis don't lose the elasticity. For example, you lengthen a tissue, ligament means it will go for the creep and then it will go for laxity. And then it will go for the tear, strain, all that. But because the subject is physically active, like maybe a basketball individual here, the elasticity of the ligament will be maintained and the length will be increased. So collagen will be getting remodeling automatically depending on the subject's activity. So this patient has a long posterior annulus and it is elastic. Elastic means what will happen? Whenever something is elastic, I would want you to imagine a kind of maybe like a wire which I have taken. It's a charging cable actually. So I do a flexion, it gets lengthened. Okay. And when I do an extension, you see what happens. Okay. So which direction it is bending? It is bending posteriorly into the canal. This is not the disc bulge which is actually going posterior and pushing the annulus fibrosis. This is only the annulus fibrosis which has got into laxity because of poor posture. It is having the good elasticity, flexion, reverse lordosis. Extension time, it compresses on the nerve root. Pardon me. So this is the actually called as the annular bulge. We don't tell it as a disc bulge because disc means nucleus pulposus. So extension will cause a radicular pain or a midline diffuse pain. But the subject turns into flexion, returns to flexion, immediately the shooting pain disappears. Because when I bend to my right side or with the extension and right lateral flexion, this compression will happen. But if I don't do the extension and I come back into flexion, no compression on the nerve root. Then compression, no compression, compression, no compression, compression, no compression. Only because of annulus fibrosis. And these patients have good hydration, good nutrition. Then nucleus pulposus will be normal. It would have never deformed. Nucleus pulposus will never come posterior or distorted, degenerated, anything. So this scenario can happen. Whether that is called as a pseudo disc bulge, but the better term is annular bulge.
Annular bulge.
Okay, so that's what this happens. Individually, everybody uses their own terminology. The same thing we see in textbooks. When authors are using, they do not want to use the annular bulge because another textbook tells annular bulge. So they will use pseudo disc bulge. Because my textbook should have a separate identity. I am an author. Okay. So that my everybody will tell pseudo disc bulge means Senthil Kumar textbook. It is there. Okay. So the identity comes. If I tell annular bulge means it is there in this book also, that book also, that book also. Any of the book you can see annular bulge. Understood? So people keep like this. Some authors have that habit. That's approximately Indians actually they do the ditto copy paste. They don't use new terms. Okay. Only the Western authors they want different identities, so they do that. And radiology to physician, all these terminologies will be different. That's why in communication, you don't expect a case sheet or a medical record to convey the information. When you have seen that, if you don't understand, means you have to ask the physician. ICU patient, you don't understand the medical record, means ask the nurse. If they don't tell, means anesthesiologist, because that they are the in charge of the ICU. Or DM in pulmonology, if anybody is there. Okay, very rare in India. Okay, so think of these all things are not important for us because MRI is the worst investigation tool. Worst, WORST. You are not going to see MRI for anything except that you are going to do surgery. The actual indication of MRI is patient wants surgery. Before that, you can do MRI. Otherwise, there is nothing to do an MRI. Otherwise, you are suspecting multiple myeloma. You are suspecting a kind of vascular lesions, all these things. Okay, because CT scan will tell about bone.
Bones, right.
That and contrast CT will tell about vascularity also. So MRI is commercially distributed and overused and abused because the cost is more and the commission that they receive from the MRI labs are more. So many of the physicians refer to MRI even if it is not needed. Before checking the patients, first only they tell take the MRI. This culture is also there. Okay, unfortunate it is, but it is there. So that doesn't mean that, and patients think that moment MRI is taken, some advanced procedure is done. Okay, and they come to you showing the MRI only. See the MRI, see the MRI, see the MRI. Okay, and if you see that the bulge that is there, the same bulge can be there in all of us, and we may not have back pain at all. So that means normals also will have abnormal finding, and people who have severe radiculopathy has a normal MRI also. Abnormal people having normal also. So that means there is low sensitivity, low specificity of the utility of the MRI or the diagnostic validity of an MRI. We are not going to have that at all in our mind at all totally, and it is equivalent to any other paper in the dustbin. Although the patient spends 6,000 rupees for the MRI or whatever. And we as physical therapists, the treasure, The diamond that is in front of us is the patient. We cannot ignore the diamond and go behind a dustbin paper. Okay. Even lab test report also does not matter at all. I'll tell you, if HLA-B27 is positive, does it mean that it is ankylosing spondylitis with the RA factor negative? Okay. So does that mean that your treatment is going to be different? Whether he is ankylosing spondylitis or not, or he has taken the HLA-B27 test or the RA factor, rheumatoid factor test or not, he's a human being. He has a functional problem. He has pain on prolonged sitting, which is not there on standing. When you are examining, his flexion is abnormal. His muscle activity is abnormal. You are palpating the muscles with contraction of that muscles. That is producing the exact pain of the patient. You are taking a history which is visceral disorders, and patient is telling that, yes, I had a renal calculi. And the right side renal calculi, same side right side is having the quadratus lumborum, trigger point. Like how Ritu ma'am was highlighting here. So then you connect the dots and you see that, okay, 3 years back he had renal calculi. Muscle pain started coming 3 months back. And now sitting, prolonged sitting and pain coming to the leg started 3 days back. So visceral can be primary. But even then, you as a physical therapist should equip yourself with skills. Not only history taking or communication skills, that is also important with patient. Okay, you have to ask questions to explore. Every patient do not tell everything to all the physios. You see, some physios will ask a question, patient will tell, this question nobody asked me. How did you find it that I had that problem 15 years back? Okay, so they will ask. So anything is possible. So never analyze an MRI report and focus on what you will examine in the patient and see for what are the mechanical issues in the patient. Whether it is a kinetic problem or a kinematic problem. That is the force closure and the form closure. Or the stability issue or the mobility issue. Stability in terms of posture causing symptoms, mobility in terms of movements or activities causing symptoms. A patient who is walking and then having back pain is lower extremity, sacrum, then lumbar. So you have to clear the lower limb, pelvis, then come to the lumbar. But if a patient is forward bending or rotating or working on the monitor and getting the back pain, you should clear upper limb, then thorax, then lumbar. It's the activity which actually is the primary pathomechanic that you should actually analyze. Even upper limb problem can affect the lumbar. If you have rotator cuff weakness in the shoulder, definitely, as Ritu ma'am was telling, latissimus dorsi will work more. The thoracolumbar fascia. Remember, rotator cuff is for external rotation. All the 3 muscles are external rotation. Subscapular is only is internal rotation. That external rotation clears the impingement in the shoulder. So latissimus dorsi is an internal rotator. So if you have all the external rotators being weak, all the internal rotators are waiting when we can act more. And latissimus dorsi wants to show off that it's like the in-laws who stay far away from the house. They never come to the house. Okay, sister-in-law, brother-in-law. But suddenly, once upon a time, they'll come to the house and they'll start questioning too much about the mother-in-law or the father-in-law, whom you are taking care. Okay. Latissimus dorsi wants to show off, I am far away, but still I have a control. So it will overact because the longest muscle is the second order lever, the lever of mobility. So that will always produce the excessive movement. The third order or the first order levers are for stability and power. So subscapularis might be a third order. Okay, as you see for the rotator cuff, because origin and insertion are closer to the joint. Insertion is closer to the joint compared to the origin. Every region, when you apply the physical principles or the biomechanical principles, you might ask a question with the patient. Patient will tell that, yeah, I had a frozen shoulder, but now no pain. Okay. So that means you will find that the restriction of latissimus dorsi on the side of the frozen shoulder, which is creating a rotation imbalance in the lumbar spine. And that rotation imbalance in the lumbar spine is abusing or overusing the quadratus lumborum, which is already made vulnerable because of renal calculi. So what I'm trying to tell is multiple segments will be linked. It's not a must that you have to link all the segments, but it's a must to clear whatever can be pathomechanically linked. Those things you have to clear, then go for the independent examination regionally that is there. So if a patient is walking and getting back pain, means first question I'll ask is whether different footwear is affecting your back pain. So that foot and ankle I am clearing. I will ask that whether cycling is also causing back pain or only walking. That I am clearing the knee joint. I will ask whether for hip joint, we usually don't do any much activity like in cycling also it comes. Okay, squatting. So squatting itself is causing back pain. Hip and pelvis. Okay, both are there. So if all these are not causing and only walking is causing, that means it's an interaction between ankle, knee and hip, all the three together. Next thing comes. So then after that, I go seeing whether the arch is flat, whether the genu valgum varum is there, the right side back pain is there, the same right lower limb, whether internally rotating femur, anteversion, or the genu valgum, or the pes planus, the rear foot varus. I am telling some few examples. So this is a kinetic chain, lower extremity kinetic chain. It's not a huge abnormality in one segment, but it's a little abnormality everywhere. And they add on functionally. That's why walking initial steps will not produce the back pain. It will produce back pain after half an hour of walking. So that means the muscles are substituting. They can manage for a low level of activity. But when you prolong that activity, they become symptomatic. They affect the other regions. Especially if hamstring is tight or you have iliotibial band, the tensor fascia lata to be tight or piriformis to be tight. Definitely they will make the pelvis to be rigid. So the lumbar spine will be moving every time. So you are likely that to injure the soft tissues of the lumbar spine. The same thing happens in an elderly. You are suspecting more of osteoporosis, degeneration of the disc, because that pathophysiology comes there in the elderly rather than pathomechanics. What we spoke yesterday of pathokinesiological model. Because age-related tissue changes are there structurally and then functionally habits. But habits-wise, if you see, they will stand only 5 minutes. You'll be wondering, I am standing for 5 minutes, nothing is happening. Another 80-year-old man standing for 5 minutes, nothing is happening. Why this patient alone is having back pain? That means it is the bone strength. The pain can be from the vertebra bone itself. Bone marrow can cause pain because of osteoporosis. So you don't have to think that it is always all the pain is disc only, or all the pain which is coming to the leg is radiculopathy only. Okay. So a bulge, pseudo bulge, whatever, it can be there anteriorly also during flexion. And it can cause vascular pain because inferior vena cava is there and descending aorta is there. just in front of the lumbar vertebra. Okay, anteriorly. But muscles wise, of course, we have the psoas and yeah, that's all. Okay, psoas only. It is in the lumbar vertebra. Psoas major and then lower part is minor. So when anatomy comes in the mind that these are the structures which are near to that, so they may get affected. Pathomechanics comes with the activities which the patient complains. And you have applied reasoning that, yes, through this and this and this, there may be a link. So first I have to clear that. So then you go ahead with the local evaluation and treatment. Individualize as per each and every patient, because I am only having right side back pain 3 months back. Now I am having left side back pain. Is not the same. Dominant and non-dominant leg itself is different functionally. And so never think, even if the patient tells that my friend had a same radicular pain, now I am having the same pain, doctor. You gave the treatment, give me the same. Some patients might tell, although you will treat them as per their expectations, because patient expectation is a big placebo, you have to treat. But you don't get fooled that it is the same disorder. No two people will have the same disorder, or no person will have the same disorder, same level of clinical presentation when it comes even recurrent. First episode versus second episode also. Okay. And the same disorder which has come on day 1 will be different from day 2. So that dynamicity, when you are able to pick up, you are a clinician. So that way you should focus and see these mechanics and all. We tell lateral flexion to same side narrows the foramen. Okay. So that means it can narrow the foramen and then the nerve root or the plexus can get compressed. Lateral flexion. But we should also see there is much more beyond this. There are different types of disc herniations. Posterocentral, posteromedial, posterolateral, and far lateral. So there are 4 types of herniations here itself. And posteromedial herniation will never get compressed when you bend to the same side. In fact, it gets decompressed. The patient will have relief of pain when bending on the same side. Radicular pain, centralizing with same side lateral flexion. So every level you can think of. And if it is disc means, bending to opposite side will bulge the disc. Nucleus pulposus. Bending to opposite side will push the disc. Foramen will be open, but the disc will be pushed when you are bending to opposite side. So it will aggravate the symptoms. Same side you will be bending, foramen is closing. You will be expecting worsening of the pain, but the disc has moved to opposite side, so there is no compression. So if it is discogenic radiculopathy, the behavior will be different. Nucleus pulposus versus annulus fibrosus is still different. Okay. That is why our master class will go beyond whatever I have described now also. It's like journey into space. But I was happy to see that it was 2021 and then September, okay, 19th September, where some of the screenshots Ritu ma'am had shared. I was thinking it's almost going to be 2 years now, okay, the lumbar spine specialist course. I wonder if I take tomorrow, then what all I will add on, okay, for each condition. Thanks to Dr. Darshana and Ritu. So this is something which we all need to explore as a human being. Okay, because it's not that what is there in the textbook is the end of the story. The knowledge is ever evolving, and we need to think ahead. We have to learn ahead. We have to be prepared for the most complex and the most unexpected scenario. Then the routine ones will be like, okay, so it's very easy to just get the reasoning right. And it's as long as patient improves, everything what you did is correct only. Okay, don't it's not a problem. But don't focus on symptom. Focus on what is causing the symptom. Okay? If you treat the mechanics behind the symptom. Patient tells the MRI is having the disc bulge. Disc bulge means you tell them, are you having the pain throughout the day? 24 hours? Patient will tell, no. When I am standing for a long time, then only back is paining. Then you tell, MRI was taken in standing or sitting? No, I was lying down. Lying down time you have back pain. No, I don't have. Then bulge that is there in the supine lying, it is not at all relevant to you. This is a basic, this directly we should not tell, we should get that out from the patient itself. No adult wants, this is useful, you do. We keep on telling every webinar, take the course. Nobody takes. Okay? Because adults do not want people to tell them what to do. They should feel themselves. If their conscience is true and honest. So same way here also patient should feel that. So then why are you relating your pain to the bulge? The bulge in the MRI will be there throughout the day. But your pain is there on standing. So that means your mechanics is the reason of the pain, not the bulge. So you modify the mechanics, you will become pain-free. You modify the mechanics, you will become functionally better. Don't try to modify the MRI with surgery. Because that is, if I was a surgeon, I will tell MRI is important because that is my business. And whoever comes, I will tell surgery has to be done. Because that only I know. Dogs can bark only. Cats can do meow meow only. Understood? Tigers can growl only. So you cannot tell why surgeon is telling every time surgery is needed. Everybody wants to do what they know. But an empathetic clinician will think of whether surgery is really needed for this patient. Being a surgeon also will tell surgery not needed. Those are the real physicians. And the same way physical therapist also. You see abnormality in MRI, you see abnormality in the patient, whatever. Even if the patient tells that my lordus is not there, you should know whether that requires treatment or not. Don't treat every abnormality. Treat only that abnormality which is related to the functional limitation, not even symptom. So that's the glory where you get the recovery right from first day, and that recovery which will be long lasting, worthwhile. Okay, so that should be the focus, right? So the
Yes,
next
sir.
one.
Thank you.
Yes, Pranali. POCO and all, I am not going to answer these questions. Who is this POCO? The POCO person will get certificate with the name POCO. Correct? Indrani agrees? Dharmesh, you have not put a question in the chat? Okay, now you have put. Indrani has put before that. Okay, we'll open her audio. Indrani, yes. Ritu ma'am is resting her eyes.
Hello, sir. Good evening.
Why are you again mute? What you are doing? Wait. I think Pranali and Indrani are batchmates. Okay. MPT.
Fourth year VPT.
Oh, okay. Yes, Indrani, go ahead. What are you thinking? It's not an exam.
No, sir. I was having that doubt about while I'm sleeping at night. If I'm sleeping by 10 o'clock, then I usually get up in morning by 5:30. But if I stay back late for 6 o'clock, then I'm having back pain in my lower back, means L4 L5 area. So what is the reason? Even if I'm having I'm going for a walk in evening. That time also I am having pain. Why? What's the reason?
Okay. What are you actually trying to interpret from her question, Ashna?
Yeah, I think it's still I would say just lying down having a back pain and answering would not do justice to the uh, pain. But if it is like as you were just explaining some time ago, she's explaining two things. One is lying down and having back pain, which is extension of the spine. Also walking and having back pain, which goes to more of understanding the lower limb symptoms also. I mean, lower limb interaction or anything. Just we talked about the interregional dependence of the lower limb to the spine. So, I mean, I would like to hear a little more from her before clarifying, like what
Or
can
at
be the
least
reason
want
of
to examine her. Okay.
pardon?
You have to examine. You can't just
Absolutely.
come with this history and we cannot get a
Absolutely.
picture.
No, there are so many things to it. So, if she can still further explain anything, other functional positions, or and of course that is just we're talking on conversation, but I think examining is something very important, without which is going to be like not right on my part to say, okay, this is the reason for pain. So I'm sorry for that.
Outline, at the outline, I would try to verify that it is. You sleep extra 2-3 hours, then the back pain is there on walking. Okay. Yes. If you are sleeping lesser
Yes,
means
sir.
then walking time, no pain. Okay. That walking, initial
No,
steps it
like
takes,
if
after
I'm
that does not
sleeping,
pain.
She's saying something.
I don't think she's able to hear us properly. And maybe yesterday night she slept longer. Okay. So the fact here is you can see it in 2 dimensions. The funnier side, whenever we sleep long, it's usual that we get dreams. Okay. Have you noticed this, Rachna Ritman?
Yes, very
Okay.
true.
You
Very
get
true.
into that different world. Okay. So that's when you actually sleep long.
Mm.
And in case you get up also at the usual time at 5 o'clock, you do not want to get up because you want to continue the dream and see what is happening. Okay. So maybe in the dream, Indrani was running, catching, playing, more physical activity. So then waking up, maybe she had the low back pain. That is the lighter side. Okay. Apart from the joke, of course, the water content in the IV disc, more you lie down, more the disc gets the water. The disc height increases. Okay. The nucleus pulposus gets bigger. Okay. So it's like tennis ball will become a football. So that means when the discs are bigger, what will happen in the body? The height will increase. There is a situation where 5 centimeters height can change if people are in the reclining position more than in standing. Now we know why Ritu ma'am is shorter. Okay. Because whole day she is standing and moving around. She never lies down. Okay. So the same way, because disc height reduces. For her reduced disc height, mobility will be less. Okay. It's like a degeneration. She will get spondylosis. Okay. But what for me, for example, I have also habit of working only when I'm lying down. I do a lot of things lying down only. Okay. Most of the time in the day, I'll be lying down only and doing all the work. I'll never sleep when I lie down. Okay. So at least in the adolescent age, that made me taller than my batchmates. But unfortunately, when the skeleton is taller, muscles are not lengthened. So muscles are taut. They're disproportionately in the outer range. They are in their lengthened range. So they cannot work at optimal length because the skeleton is taller. So if you have a range of motion, disc is supposed to increase the range of motion because the height is more, but the muscle is not allowing that. So we move on, we keep doing that jumping, all that vibration or travel, okay, this kind of axial loading. Then the water redistribution goes to the cartilaginous end plates, gets back into the subchondral bone, after which you'll find back is okay, normal. Here, it is like muscles which are like stiff, the side ones. So it's not a degeneration. This is only with the flexibility, but it is again a pseudo tightness. It's not actually the muscle is tight. Because the joint is moved far away, muscle is taut. It's lengthened. So it's not further, it cannot lengthen. Okay. So this kind of scenario, it's a physiological adaptation where you don't have to make a big issue out of this. It's not a big problem. Okay. But only she will be able to answer whether her height changes, whether she is growing in height with what is called as whenever she sleeps, and what is the symptom that she experiences, okay, in the muscles, and how walking is also intermittent loading of the disc. Of course, lower limb, all that is also in the picture. But you compare the supine lying, and again, sleeping position also is important. You sleep in side lying or you sleep in rotation, whichever. And whenever, at least as a empathetic or a patient-centric thinking, whenever I sleep long, I always get up in a very unusual position. Same like how the dream. So I'll never lie down on my right side. But the days when I sleep the maximum, I'll see that I'm waking up from my right side. Okay. So this thing happens. Okay. So otherwise, like even in my sleep also, I'll be dreaming like I'm writing something, I'm doing something. Okay. So my right hand has to be used. So I'll be left lying only. Okay. So these things I have, we don't explore much. Okay. Sleeping position, nobody can explore. And basically it is the water which is reiteration, which is happening to the disc. So you don't have a less mobility because of the disproportionate length between the skeletal height and the muscle length. So if you work out on, for example, playing a throw ball, a handball, or a kind of even a basketball, where loading is also there, and upper extremity, okay, thoracolumbar fascia. So these kind of activities, definitely physiologically your body will get adapted. If you are sedentary, you want to continue sedentary, you don't want to play, then definitely disc bulge will be likely. Okay, because there is excessive content. Nucleus pulposus pressure will be more water, so that can easily bulge. Okay, so that is like bending and lifting. Any kind of activity you do in the first 1 hour in the morning, you bend and you lift a flower pot, okay, which is a heavy, and you will get a nice disc bulge and radiculopathy. But otherwise, if you see towards the end of the day, when the disc height is less, same walking will not produce the back pain. For example, you are telling 6 hours sleeping versus 8 hours sleeping. Some holidays you would have slept 8 hours in the daytime or during lockdown. Lockdown anyway, online class was there. Torture was going on. You cannot sleep. But here, if you see that, some daytimes when you sleep 8 hours, you will not get the same back pain. Only the night, only long sleeping will bring the back pain. The rehydration happens as your biological clock or the circadian rhythm. Towards the end of the day, definitely water content in the disc will reduce. So the discomfort or the back pain will not be there on walking if you're sleeping in the daytime. But unfortunately, Indrani will say, I never have a habit of sleeping in the daytime. Okay. So it's fine. It depends upon the person. The important thing is, many people lose the water so much, but she has the fluid retention in her body. Generally, the risk factor for fluid retention. That may be because of hyper natremia, the sodium content in the body is more. So the tissues always take the water. Even if she does not eat, she will be putting on weight. Okay. So there are various people like that. Okay. So electrolyte imbalance, which causes water retention to be more. So the disc also retain the water because excessive water is there in the body. If you ask Ritu Mandal, water is not there only, water scarcity. Okay. So, but still, and another thing is this similar behavior of long sleep and then having back pain may not be there in situations when the water loss is there. The water loss, I am not telling about urination, but even if it's a monthly menstrual cycle where the fluid loss is there in the body, the subject may not feel that because it gets physiologically balanced. The back pain of that menstrual cycle will not be much. It will be same back pain which is coming in the morning during the walking. So you know that the body is balanced, okay, in the fluid dynamics. So what you need to do to condition it properly is the physical activity, which involves axial loading. And also, some people get into total deep sleep, like they become dead when they are sleeping. They don't even move during the sleep. Okay, they don't turn, they don't bend the leg, they never lie down prone, they lie down only supine. Okay, same position. If somebody sees them, they'll feel like whether they're sleeping or they're dead. Okay, so that kind of sleep also makes the disc to get more water. I'm not telling do the exercise in your sleep, but at least ensure that it's a multiple factors that interact together and it is not a serious problem at all. And if you have to explore more, it should be in the dimension of sleeping disorders. Okay, if at all anything that comes with not the posture or anything like mechanical disorders, it should be a sleep disorder, which is like cognitive component, and then that creates a central mechanism that I get up late means today back pain, because it is over a period of time I have been experiencing this. So if Pranali says also that she got up 2 hours late, Indrani will always look at Pranali like, you're not having back pain. You should be having back pain, na? Okay. That is central sensitization. Okay. So we try to project the same on the other person. Okay. So anybody who is sleeping for a long time, if at all they are sleeping and they're lying down, you look at that person like, now that person is waking up with the back pain only. Okay. So that is central sensitization. So that is a kind of a neural plasticity. That again adds on to the same mechanisms further and further. Anyway, aerobic reconditioning will target both. And definitely you can easily come out because of your young age. Your homeostasis will be at the perfect balance to recover. You are not 40 plus, 50 plus after 2 children and approaching menopause or after hysterectomy. Okay. So we need to see that how the body is physical versus physiological. Okay. So the recovery and the reconditioning is always possible. Right. Don't go and take an MRI. Okay. Because it is sleeping position, sleeping, getting up is there. So MRI also lying down position. So bulge is there means. Okay. Same bulge which was there in the other patient whom Pranali saw, this bulge also will be there. nothing it matters at all. Okay. So understand the physiological role behind that. Okay. Debashish. Oh, he's trying to answer. Jalat. Dharmesh. Or Debashish. Yeah, Debashish. Is Dr. Debashish there on the screen? Due to nerve compression, if sleeping posture is not correct. Whenever people tell that sleeping posture, they are people who are like, I don't know what to tell them. Okay. Because if you as a therapist giving advice to a patient telling that you have to be in right side leg only, never go to left side. If you are maintaining that posture, can you sleep? Okay. So next day patients will come and they will say they have no more pain. Any advice you give, change in sleeping posture, they will come back with more pain only. The reason is that descending inhibition is good when you have the good sleep in your routine habit. If somebody modifies that, pillow modified, position modified, anything happens, you are bound to have that hypersensitivity of CNS. So they will come back the next day with discomfort only, and they'll, if half an hour walking brings the back pain, this will come in 5 minutes. Okay. So do not modify the sleeping posture. Don't think that, and never ask a question on sleeping posture, and never advise also the patient on modification of the sleeping posture. Okay. Recommending a bed and everything, it's a shame. Okay, that our Indian Association of Physiotherapists has done, telling that this bed is the recommended by IAP. Okay. I don't think so. Why you recommend the bed and for what purpose? Okay. But ultimately, it's ridiculous to actually see that only for some patients, they lie down on different surfaces. When they have pain, that gets modified with surfaces. Surface is not the cause of pain. It is only the aggravating and relieving factor. So you don't have to modify a bed surface. You have been lying down on the same bed for 15 years. It might have got same way like a disc also, it would have got degenerated. Okay, the bed also will be like 3/4 of the width. Okay, thickness. But still, yesterday and today the bed will not change. Why today I am having pain? Don't relate it to the bed. Okay, so that is what I am trying to tell. Don't ignore the human being and the physical aspects of evaluation rather than going to the sleep postures and things. Okay, and only if the extrusion is there in the disc, it's a chemical irritation. Chemical irritations, the chemoreceptors are active in the night. So that patients will have night pain. Or sequestration. The particles of the disc will be migrating in the canal. So that during the sleep, it will go proximal. Suddenly you will feel pain somewhere, burning in the thorax and all you will feel. Okay. So what is different issue? Chemical aspects, non-inflammatory, inflammatory feature, non-mechanical. Okay, pardon me. So that is different issue. Otherwise, you are not going to talk about unless the sleep night, the pain disturbances are there. The person wakes up with the pain. Okay, then you can tell that it's a posture, for example. Sacroiliac instability. Whole day the patient is walking, muscles are working. Whenever you are walking means core muscles will be active, pelvic floor will be active. But when you lie down, the muscles are not active. This happens in the postpartum. After the childbirth, the woman, the mother lies down, she gets a locked innominate or the torsion of the sacrum in sleep. And she wakes up with, okay, it's very stiff. Ligament also laxity is there. So that is the picture there which adds on. So understand that which is the actual one which you have to relate it to and which you should not relate it to, and which ones are modifiable, which ones are non-modifiable as per your individual physical and physiological status, psychological also, all the 3P, physical, physiological and psychological. Okay. What we have as next? Yeah, Dharmesh, finally. Yes, I will unmute you.
Good evening, sir.
Yes.
Sir, how to treat the patient with multiple disc bulge with the one side of radiating pain, and when we should use the traction on that patient, whether it is affecting while we using the traction for that patient for supine or prone line.
What is my first question here is, or my thinking process, my thought is, multiple disc bulge. It's again, this is an MRI. Okay. And nerve root compression. Sometimes even MRI will tell bilateral nerve roots are compressed, but patient will tell only symptom only one side. Okay. So if I'm wrong, you interrupt and correct me. Okay, Dharmesh.
Yes, sir.
So these things will come. So what I will try to say is ignore the MRI out. Focus on the patient who is having the radicular pain and think about what has exactly caused that radiculopathy, whether it's a degeneration, whether it's a disc bulge, whether it is the instability of the lumbar spine that has caused the radiculopathy. But in this picture, I suspect the instability to be a higher priority because of multiple disc bulge. But remember also one thing, L5, S1 disc bulge, L4, 5 disc bulge. These two only clinically are important. L1, 2, 3 and all disc bulge is not at all important because they are not that much mobile. The L1, 2, 3 and all, it is for lateral flexion rotations. And what is L4, 5 only, maximum it is flexion extension. Okay. That's why they affect the disc more and all the stenosis, radiculopathy, everything common in L4, 5, not in the L1, 2, 3. Some other reasons why multiple disc bulge happens is because of a connective tissue disorder. People have ligament laxity everywhere, or a kind of a connective tissue disorder like ligaments, connective tissue disorders. Sometimes like, I think it's collagen vascular disease, which changes the collagen fibers. Okay. So because of that conversion of the collagen fibers due to a vascular problem, and the subjects have laxity, they will have disproportionate elasticity with the same tissue. Collateral ligament means anterior part of the ligament will be like laxity, posterior part of the same ligament will be thick and hard, no elasticity. Okay, that imbalance. So this is a connective tissue disorder that will create multiple disc bulge. Mechanical problem will not create a multiple disc bulge. Okay, it's very rare that you will have that. Okay, so it may not be important at all, the other levels wherever the bulge is there. Whenever subject is having radiating pain, you have to see that which dermatome the radiating pain is there. That will give a clue on whether it's a L5 radiculopathy or S1 radiculopathy. This is assessment. Okay, it's not biomechanics. It is assessment. And then you see for L5 and S1, among that radiating pain, some patients will have back pain more than the leg pain. Some patients have leg pain more than the back pain. Some patients have this radiating pain in a Valsalva maneuver. Some patients have this radiating pain in a SLR, and other patients have this radiating pain in a Sperling's or foraminal compression test. And the least number of patients have this radiating pain after walking. So, MRI, I am not going to discuss anything. I have to see which type of patient the picture is fitting. So everywhere, every condition comes. It's a different condition, different spectrum of approach to treat the patient. So radiating pain is not just we treat the spine and the leg, we treat the patient. And in a patient who has neurological deficits, sensory, motor, weakness of the muscles, that is radiculopathy. Without the neurological deficits, it is radicular pain syndrome. So there are a lot of differential thinking as a come based upon the upgradation of knowledge. You don't treat only the MRI, you don't treat only the history. You have to examine the patient. So that means clinical skill has to be upgraded. So biomechanics has to be bridged to understand what are the clinical findings that are coming. As we have been talking about bending to same side, bending to opposite side, we have described enough and more about the radiculopathy. So if you do not do that in examination, it means that sun is right in front of us and we are closing our eyes because it is glaring. And we think that it is night. I don't know how to go. Somebody show me the light. The point is you have to open the eyes. So upgrade that is the solution. See, if you see every case example, whatever solution you are asking, ultimately you are asking because you don't have anything in your hand to choose from. If you have 10 in your hand, you can ask whether I can do 1 or 4. So that will come with a sound knowledge, the comprehensive knowledge. So that comprehensive knowledge, you only should decide where to get it from. By searching Google and watching YouTube, you will get, or by genuinely enrolling into courses and get. When we had the demonstration of chiromanual therapy where radiculopathy and spinal activator method, there were some pictures which were like with TheraBands applied on the body. People were asking like, what is this technique, sir? For radiculopathy, why TheraBand is there? You understood? So this is the things which you have to explore. When you're treating a patient, every tissue is important. It's radicular pain, so only I'll treat the nerve root. No. You are not a radicular therapist. You are a physical therapist. So we need to think beyond the symptoms. And the examination, physical examination is also important. Everything what we have. In AOMPT, we do SLR with 25 variations. It's not just a SLR with a supine lying, you just lift the leg. So imagine radiculopathy, how that differential reasoning will come if you are doing 25 different variations of SLR. We can find out whether it's a degenerative disc which is causing the radiculopathy, whether it's a disc bulge which is causing the radiculopathy, whether pseudo disc bulge causing the radiculopathy, whether nerve root tethering or injury causing the radiculopathy, whether it is only the radiculopathy or with the ganglia autonomic, whether the radiculopathy is posteromedial, posterolateral, whether it is L5 or S1. Everything in one position subject is there and we are doing all the tests. It's not even we are changing positions. That is the pathomechanics actually, which is totally absent in any of the literature anywhere in the world except AOMPT. I can give an open guarantee. If somebody else teaches pathomechanics with a demonstration and they have shown after taking AOMPT video, if you feel that similar video is there in YouTube, and if that video was before the AOMPT's video, we'll give all courses of AOMPT free to you. Open challenge. Okay, we are the first in the world to explain to such depth. Your honest consciousness should show now itself that the thinking process goes beyond what we actually see in the textbooks routinely. Indian or Western textbooks. Nothing there. It is your common sense. It is your dedication to the patient will develop newer and newer techniques, which both Dr. Ritu ma'am and Darshana ma'am have been my clinical hands. Okay. If I am intellectual, the brain of whatever the changes that we have made, the development that we made as techniques and evolved the clinical approach, they are the hands. They are the executing motor part. Okay. So, and also sensory because they are watching, they are receiving the inputs. But maximally, they are the ones who are manifesting into the reality. Okay. People asked me, sir, you are treating patients in the academy? How many patients you are seeing clinic this, that? I told I don't touch a single patient. But what they touch, I feel that. What I teach, they feel that when they're touching the patients. Okay.
That's absolutely true.
This is the two-way communication, which is impossible in any context, anywhere in the world between any teacher and any participant. Okay. Which AOMPT is bestowed with that. Because it's destiny. So, when people are, you are all part of it, you will get the resonance of what Ritu ma'am is presenting, how dedicatedly she is sharing the knowledge, how the screenshots when you saw, nerves and all with tape and all demonstrating. I see that as a student. Okay, how visually it is giving me the information, the clarity of understanding. When you do a neurodynamic test means which nerves are getting influenced, how we can be modified. We all talk about SLR with internal rotation. Why can't be an SLR with external rotation? Why can't be an SLR with a muscle activation? Why can't be an SLR with trunk different positions, laterally bent to same side or opposite side, then SLR? It has to come because we are physical therapists. We should evolve, make it more better and better because we have the foundation, the biomechanics and the pathomechanics. Although it was improperly taught in the college, doesn't matter at all. There are people who know that. So learn from them. You will build upon that because they teach you learning. They don't teach the subject. So they teach how to learn so that you learn much better and you develop newer techniques to match the reality. Okay. So every question, whenever you are asking, it's here, it is like, of course, you are asking because it's a requirement for the certificate. I can easily understand. Okay. But Dharmesh had asked the second part of the question where traction in supine versus prone. When everybody advises that supine, 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 something made him to think that can prone be better? Because gravitationally the disc material will go back. If, for example, if traction is given in the prone lying position, that means the disc bulge which is here, gravitationally this will go down. So prone traction may be better. It's okay, no problem. I am not a god to tell this is better, that is not better. Use it on the patient. If patient becomes better, continue the prone traction. There is no hard and fast rule that stops you from giving a prone traction. And why prone traction we don't prefer? Because the leg is also extended. Okay. If like this, the hip is also extended. Okay. In a prone traction. And it creates an extension. That extension will narrow the foramen. So the ultimate purpose of distraction is nullified. But if you keep the patient in quadruped position, where the leg is flexed 90 degree, And then the pelvic traction belt is kept. The supporting for the feet we are using under the leg, that supporting stand is there, stool like. Keep it for the body. And subject is in quadruped position. Now you give the traction. Here, lumbar spine is flexed. Because this is quadruped position is also flexed, same as the sitting position, same as the supine lying Fowler position. So here also it is flexed. So it will not close the foramen. And this is gravitationally will reduce the disc material back also. So you can always give. Think. You should explore more and more like an adventure. You have gone to a mountainous place, waterfalls, animals, okay, birds are shouting, which each sound that comes in that jungle, you will turn and see. That bird means, that sound. One animal sound means, which animal? We'll be searching here and there. Same like that, every clinical finding, you try to explore new and newer. Adventurous attitude should be there. The creativity has to be there. And then see, if quadruped position when I am keeping, this is the radicular pain side. So that leg, I can keep even extended. I don't have to flex. Other leg can be flexed. I need only a support. Understood? Other leg is flexed. So lumbar will be flexed only. And see that depending on the foramen, I can do a lateral flexion. Which side I am laterally flexing so that the symptoms are centralizing. That is only to the back, not below the hip. Or if it was below the knee, it should come above the knee. So that is centralization. So I bend to the opposite side, it is above the knee. When I bend to the same side, it is below the knee. I'll choose the opposite side lateral flexion also. And rotation also I can modify. So that means don't concentrate only on whether it is supine or prone. Concentrate on flexion, lateral flexion, rotation in every combination you can keep. And then apply the traction. Even a supine traction when you are giving, laterally bend the subject to the opposite side or same side and see whether that traction is more effective. Rotate the patient's body. I have a brown visitor here. Can you see that? Okay. So this is a wedge pillow. So this pillow, when you lie down, it rotates the body. Okay. So it definitely rotates the body because the upper body will be straight. Lower body is rotated. Our whole body can be rotated. It can be in supine also or prone also. All these days, why did we didn't think of a wedge pillow? So these are things which has to come as a movement scientist. It's not just doing Pilates or working out in the gym alone will make you a physical therapist. Or learning osteochiro alone, okay, make you a better expert physical therapist. Unless you concentrate the pathomechanics and you do not explore, you are as well as a person without the eyes. Okay, not even blind. Eye itself not there. Okay, so ensure to explore, get the direction with the better courses. Your conscience should tell you, such an instructor I have never seen, such an information nobody has told. So that means you have to take the plunge because your destiny is waiting to transform your life into before and after the webinar or before and after the course or before and after AOMPT. Because this happens in everybody's life. In your life, it is not yet happened. It is you who are postponing it. So ensure to see even radiculopathic course, the 3 hours, which is 1 hour pathomechanics and 2 hours video alone also you can purchase. Just to have an idea how extensively that it has gone. So we have what to say? Even during traction in the prone lying, okay, traction is applied in the prone or the quadruped position. That time also you can give spinal mobilization. Traction is pulling, you are giving mobilization to the spine. So remember, it is like MWM only, mobilization with movement. The movement is distraction. Mobilization is what we do with the thumb or an activator tool also. So everything, of course, I'm revealing the suspense of what will happen on Saturday and Sunday. But these things you need to explore. Don't just take like a side-lying thrust manipulation. I will also do that. Okay. Think beyond what the technique is and focus on the patient. Okay. I hope cricketers. Jalat James. Sorry for the same. It is like a poem. Poco. Sir, my name is Jalat James. Sorry for the name. Sorry for the same, it has to be. Okay. I wasn't able to change it after joining. No problem. You have to right click on the participant list. Then you can change. Kiran Nodial is Dr. Kiran Nodial on the screen. I don't think so. She is there among the participants also. Yeah. So, cricket players, the fast bowlers report low back pain while throwing the ball. Pain is dull during walking. This is the thing. Bowling or throwing. Okay. So, it should be bowling only. And pain is there and walking also. Okay. This is just the history. Where is the examination? Okay. Why are you questioning history? If you have to question history, question the 2002 BBC documentary. Okay. What has recently come? Whole India is shaken because of the BBC documentary. It happened 20 years before. How can you question history? Okay. So do examination. See what the person has done. Person not able to do. Okay. Ability, the inabilities, the functional influences. Then only that is the evaluation. So then you decide. Okay. Pain is there and walking means everything can cause pain. And bowling, stress fracture, don't jump into the fact that everybody is not a Jasprit Bumrah. Okay. Bowlers be getting back pain means it is Jasprit Bumrah. Okay. So the same like that. SLR positive means radiculopathy. Don't jump into this. Every bowler who is having back pain is not Jasprit Bumrah. Okay. Same way, don't think that diagnostic labeling immediately. Okay. So try to see the mechanical interplay. Then you will go into the depth of addressing the actual issue. That's why clinical discussions has to be there. Like when you treat a patient, case-based discussions. Another therapist also case-based. So all are trained similarly and they all discuss. So then more and more deeper exploration will come. Okay, so how much we can improvise our thinking process. A Valsalva maneuver, which we think that it will provoke the disc symptoms, but it can also relieve the disc symptoms. So everything is possible when you see the magic of mechanics. So, madam is totally closed her eyes because it might have been double to triple. Okay. Yeah. She's having the eye strain. Okay. And today is not the best time actually. Immediately when she had the yesterday retinoscope examination, and especially without the glasses, when she focuses on the laptop, will be more straining. Right. So we will close the session.
Yes, sir. Perfect.
Right. People who have not asked their questions by directly being visible, remember only Indrani and Dharmesh and Pranali. Okay, they asked the question on the screen video other than Dashna. Right. Chaitanya ma'am joined. Okay. So we'll close the session. I will stop the YouTube streaming.